Good evening. Today is World Suicide Prevention Day, and the British Council Library marks the day with a program which we hope will create greater awareness and understanding. The discussion of suicide is taboo in many societies. It is painful and it is shameful. Stigma is literally killing people. Suicide takes away loved ones, young and old, across all continents, men, women, and children. We need to say, you are not alone. Speak up, seek help. No one is at fault with mental illnesses. Only too often we ask why when it is too late. Why do we show our laughter and not our tears? We hope we will come away from this evening's program with better understanding and empathy. It is a privilege to host three very qualified and experienced people and hear what they have to say about their work with suicide and self-harm. This session will last approximately 90 minutes. Please include any questions or comments you may have in the public chat section, and we will address them in the Q&A segments. Our first speaker this evening is Dr. Alexis Palfreyman. Dr. Palfreyman is a public health scholar activist with a multidisciplinary background in sexual and reproductive health and rights, violence, global mental health, and suicidology. She has worked extensively in Sri Lanka, generating the most comprehensive and gender-conscious evidence on the changing nature of self-harm in urbanizing Sri Lankan communities. Dr. Palfreyman's work argues that a continuation of current suicide prevention efforts are not only insufficient, but potentially counterproductive for reducing risk in their present form, particularly for Sri Lankan women and girls. As research fellow at UCL's Institute for Global Health, she is co-leading the Violence and Mental Health in South Asia WAMSHA study in Sri Lanka, which aims to develop a mental health package of care for survivors of gender-based violence, modern slavery, and conflict in South Asia. She is perhaps the only suicidologist living and working in Sri Lanka. Dr. Palfreyman will give a brief background to suicide, including in Sri Lanka, and she will take a few questions at this point before she proceeds to present on maternal mental health and self-harm. The mothers aren't all right. Self-harm and mental health in the perinatal period. Welcome, Alexis, to this session. Thank you so very much for joining us.
Thanks. Good evening and welcome to everybody who's taken the time out to join us tonight. I'd really like to extend my gratitude to everyone for being part of this World Suicide Prevention Day discussion. As Renali said, I'm a critical suicidologist, and what that means is that I study everything to do with suicide and self-harm. And I've spent about the last 7 years focusing on working with families affected by suicide and surviving men and women who have self-harmed in the past, as well as health and social care providers in Sri Lanka, to work out a better understanding about why people self-harm at the time that they do and in the way that they do. To begin our evening together, I'm going to have some slides to share with you. These figures hopefully will give you a better idea of some of the things that we're talking about. I want to start out by laying some foundational knowledge about what suicide and self-harm are, how and where we find it happening, and who it affects at the global, regional, and national levels. This is a real whistle-stop tour of recent trends, but it's hopefully a gentle introduction to some of the issues. I first want to clarify, there is a phrase that I use in my own work, which is not common to everybody working around self-harm and suicide, which is self-directed violence. You'll hear me use this phrase tonight, and the reason for this is important. So self-directed violence simply means violence that someone directs towards themselves, not towards others. And when we think about it in this way, what we see is that deaths, what people tend to call suicides, are actually the most physical, extreme physical outcome of this form of violence. But it's actually a whole spectrum of thoughts and behaviors that can be suicidal or not in their nature, and they can be deadly or not. What makes something suicidal whether it's a thought, an attempt, or a death, is that the person understands at the time that the outcome of that experience would be no longer living. And people travel different paths. People travel different paths through their experiences of self-directed violence. For example, you can see these two people could start out having very similar kinds of suicidal thoughts about thoughts about hurting themselves, which are not suicidal in their nature. But then they can progress quite differently. So here you see that the woman is in the same place while the man has actually moved forward, and he's moved on to having more specific thoughts about planning what suicide might look like for him. This other person, though, this student, may actually have an experience of choosing to self-harm quite suddenly, perhaps in response to a really significant life disappointment or a loss. And so he tells us that not all people actually experience a period of thinking a lot about hurting themselves before they do. Genuinely sudden acts of self-harm are quite rare. There is usually a buildup of trouble in their lives, even if they're not quite recognizing all of that. But eventually it sort of takes its toll, and there can be these sort of huge life changes, huge life shifts, which are felt to be a bit of a tipping point. We see this quite a lot in Sri Lanka. But it's important for us to sort of see these different paths, because what it means is that almost all of the time there are opportunities to listen, to notice, and to support someone so that these events don't progress. Thankfully, almost everyone who has considered suicide or has had thoughts of self-harm, they never go on to plan or actually act on those thoughts. And for most people who do self-harm and survive those events, they never go on to do it again. So it's quite a small number of people that do that. Sadly, like this gentleman, we do see a minority of people who do make the decision to take their lives. And I think it's really important to have this kind of bigger picture of the whole spectrum and to understand what it means for something to actually be suicidal. Because when we hear that someone has died by suicide, we make kind of all kinds of assumptions about their behavior and their choice. We hear an awful lot about suicides and suicide attempts in Sri Lanka, but we should understand that actually much, if not most of the time, what people tend to call suicide attempts here may have actually been self-harm where the intention wasn't to die, but the intention was to get some kind of change or relief in another way in someone's life. And what that also means is that with the right kind of support, those individuals can go on to recover and to never have that experience again. So this is all just something to keep in the back of your minds when you start to read statistics on suicides and you hear people talking about these events and sort of labeling, categorizing them. So now that we understand what self-directed violence is, let's talk about how much it happens and where it happens. Globally, we see about 800,000 deaths from suicide every year, and we know that this is an undercount. For every person who dies by suicide, we estimate that about 20 other people have had suicide attempts. And for every person who dies by suicide, we also estimate that about 6 very close family and friends are deeply affected by the loss. In societies like Sri Lanka, where extended family are much more deeply involved in everyone's lives, that number of affected people left behind is actually quite a lot higher. And so you can see that suicide leaves behind a trail of bereavement in its wake. What we don't have great estimates on is how common self-harm is that doesn't end in death. And in most parts of the world, we have pretty patchy evidence on this. WHO has actually just released new guidelines for countries to get better surveillance systems in place so that we can make sure that we're not just focusing on deaths anymore, but we're starting to pay attention to people who land at all those different points along that spectrum. Now, you may notice on this map that there are a lot of heavily darkened areas in the global south. And that's because, unfortunately, low and middle income countries, most of which are in the southern hemisphere, experience the overwhelming majority of suicides, about 80%. And yet, these same countries are the ones working with the fewest resources and the most limited knowledge to actually tackle the problem. South and Southeast Asia are global epicenters for this crisis. And while other regions of the world are seeing pretty steady declines and some really impressive improvements, we are really still grappling with suicide and self-harm in our neck of the woods here. There's also something else worth understanding. If we revisit this spectrum, which we went through earlier, what we also see is that suicides are much more commonly confirmed in men. And all other experiences of self-directed violence are far more common in women. Globally, this is true. And so we have this gender paradox. What happens is when we only focus on suicide, which of course is too late for the actual person we're talking about, we miss not only half our actual population out of the conversation, but we're missing the biggest proportion of people experiencing these earlier stages of risk. South and Southeast Asia also don't have hugely different suicide rates between men and women. It's a much more balanced picture. And so again, what that means is that women in South and Southeast Asia, including Sri Lanka, are more commonly engaging in suicide compared to women in other parts of the world. India alone actually contributes 40% of the world's female suicides, and Sri Lanka has the second highest contribution to female suicides in the region. I'm happy to talk more about the gender paradox, but I want to progress on to wrapping up so that we talk about the Sri Lankan story. So Sri Lanka itself has had a really interesting history with this problem. Historically, Sri Lanka had the highest suicide rate in the world in the mid-1990s. And with really progressive and aggressive efforts driven out of a presidential task force in the mid-90s, and with support of WHO and big agriculture companies and others, we have managed to reduce the deaths from suicide by about 70% because we brought down deaths from pesticide poisonings. Coupling that with better treatment in hospitals for particular forms of self-poisoning, we are now ranked about 29th in the world instead of first, which is a huge accomplishment. And while this is wonderful, I firmly believe that for the better part of the last 25 years, we have sadly been a nation of kind of a one solution approach to suicide, which has been around restricting the means, and specifically around restricting access to pesticides. What that has resulted in is a continuation to fail thousands of other families and individuals every year across the country because we don't pay attention to all of these other potential strategies. Non-fatal self-harm is increasing every year in this country, and young people in particular are showing year-on-year increases, especially in women. Finally, I just want to wrap up by giving some take-home messages. So at this stage, I'm going to highlight these key takeaways, and we can revisit them later if anybody has questions. But in brief, I want you to remember it's not just about suicide. People experience self-directed violence in many forms for many reasons, and women actually experience self-directed violence much more than men everywhere globally, although men are more likely to die by suicide. Once someone is suicidal, they're not always going to be. Most people never progress to a more serious stage of their experience. And that means that there's almost always opportunities in a person's path for us to intervene. Finally, all too often, families bereaved by suicide are ostracized. In suicidology, this is something that we refer to as the change of address book phenomenon. And what happens is that suddenly people they know, including family, can't be reached or don't want to associate with them. And people who survive self-harming events, or even those who go on to share that they've had thoughts about suicide, can often be met with a lot of criticism, shame, and guilt tripping. So I just want all of us to have a deep think, and we can talk more about this with Fergus and Nivendra about how we can make sure that none of us participate in those kinds of behaviors, and that we are always kind of supporting productive conversations around self-harm, particularly with people who choose to disclose with us. And so with that, I'm going to stop my whistle-stop tour, and I'll invite some additional questions if there are any.
Alexis, can you hear me?
Yes.
Okay, so yes, we have a question. We have a couple actually. Shall we take them now?
Yeah,
So
sure.
it says, we often see that people who go through some tragedy are able to channel their pain into something productive, such as intense workouts and weightlifting exercises, etc. These things cause pain, and thus it might be a hard activity to perform.
Mm.
Is the tragedy induced ability to increase pain threshold connected with an ultimatum of self harm?
So I actually think someone like Fergus might be better, or even Nivendra might be better suited to answer this because of their clinical roles. We certainly know that people who engage in repetitive self-harm, so people who do it as a sort of stress or pain relief activity on a regular basis, which in Sri Lanka is a very, very small number of people, we do see generally a sort of growing pain tolerance over time, which can then mean that the activities that people choose to engage in get a bit riskier and riskier and riskier. And it's also one reason why sometimes we end up with cases of what looks like suicide, but may actually have been a case of self-harm that was miscalculated. So it was done for the purpose of relieving stress or tension, and they miscalculated the risk involved, and it ended up as a fatality. But in those cases, we actually would qualify it as an accident, not a suicide.
Okay.
But yeah, I think, so there is definitely a relationship with pain thresholds. But in terms of exercise and those kinds of physical stress inducing activities, I think Fergus and Nivendra are probably better suited to answer that.
Okay, yes, I think Fergus has said he'd like to take it up later, so we will bring that back. I also had a question. You were talking about self-directed violence. Is it also that internal monologue that some people have where they're very, very critical of themselves? Is that also contemplated when you say self-directed violence? Because I think sometimes thoughts can be as damaging as actually what you do to yourself.
Yeah, so I think it depends how much. It's interesting. So in Western countries, a lot of the time we describe suicides as monologue activities. So someone is ruminating and thinking a lot of distressing thoughts, a lot of self-deprecating thoughts, etc. And the suicide is kind of coming from this place of, this is kind of how it's pitched in Western countries, and the evidence has kind of long presented it that way. In Sri Lanka, we actually don't talk about these as being monologue events. We see them as dialogue events. So the vast majority of the time, self-harm is actually used, whether it's fatal or not, is actually used as a communication strategy with others. And it's an externalizing behavior to get something in your life to change, whether it's to get your husband to stop cheating, the violence in your household to calm down, etc. It's your parents to stop being so hard on you about your exam results. So it's used as a communication device much more overtly here than it is in Western settings. Although that we can debate that, but anyway, that's how it's presented in the sort of two distinct bodies of evidence. But yeah, I absolutely think, of course, there is an element of someone having to perceive that their circumstances and their existence is not worth sustaining, right? So there is an element of not valuing yourself enough in many cases, yeah.
Okay, let me just see, there's one more comment on the, okay, no. So we can proceed if you like to go on to the next part of it, because I think Fergus would like to pick up quite a bit of this in the discussion. Yeah.
Great. So for this, I don't want to use any slides. I just want to sort of speak to everyone. I want us to take some time to look in depth at a part of our population that is chronically neglected by partners, by family members, by health and social services, and that's mothers. My rationale for this, I hear all the time a lot of people say, that's a very niche topic. But I'd argue, the only reason any of us exist is because of a mother. And we all have at least one active relationship with someone who is a mother in our lives. 51% of the world is female, most of whom are mothers or will be mothers at some point in their lives. And finally, the rationale for focusing on this is that motherhood is actually a journey, and it often begins long before becoming pregnant. And it continues, of course, long after a pregnancy ends. So this is really relevant for families, partners, and frankly, anyone who wants to support mothers through this really critical role in their lives. So the way that it is now globally and in Sri Lanka, maternal health services really continue to prioritize physical outcomes. And specifically, they're heavily focused on babies' health during pregnancy, babies' health in terms of outcomes. And then they're also focused on preventing really extreme scenarios of maternal deaths and permanently injurious births. But as obstetric care around the world has continued to improve in many ways, and deaths from obstetric causes like postpartum hemorrhage or sepsis have fallen, what we're actually seeing around the world in all kinds of different settings is that deaths due to suicide have emerged as a significant, if not leading, contributor to preventable deaths in pregnancy and the postnatal period. Maternal suicides are now the leading cause of pregnancy-related deaths in the US, the UK, parts of Australia, Hong Kong, Nepal, Bangladesh, Mozambique, and in Sri Lanka. So in recent years, evidence from the Family Health Bureau has confirmed that nearly half of those maternal suicides in Sri Lanka were in pregnant women. In addition to that, there is an ever-growing body of evidence around the world that common mental disorders like depression and anxiety are the most common negative outcome experienced by pregnant and postnatal women. So more common than swelling, more common than stretch marks, more common than, all the kinds of morbidities, negative health effects of pregnancy that you can imagine. Mental health issues are actually commoner than all of those. In low and middle income countries like Sri Lanka, 1 in 6 women in pregnancy experience depression, and 1 in 5 women in the postnatal period experience depression. And we know that poor mental health impacts the course of a pregnancy, the course and the health of a pregnancy, labor and birth outcomes, childhood outcomes, and it's the single strongest predictor of postnatal depression. So what that actually means is that waiting until the postnatal period, you'll often hear lots about postnatal depression, but the reality is if we wait until the postnatal period to care about women's mental health and their emotional well-being, it is too little too late, particularly for women who end up dying by suicide. So there's really an urgent need to identify women as early as possible. So with this in mind, I embarked on the first dedicated piece of research in Sri Lanka to look at mental health in pregnancy, focusing on suicide risk and depression. I spent time with more than 1,000 pregnant women in Western Province, and this was in an urban and urbanizing part of the country many of you will be familiar with, and I screened them for risks, for these risks, and then spent time with them sort of triaging them to extra support if they needed it. The important thing to know about this sample of women is that it included women from all trimesters of pregnancy, from all ethnic groups, all language groups, all literacy levels, and in the community and hospital-based settings. So it's a really solid piece of evidence that included women from every conceivable background in this part of the country. And what we found is that actually Sri Lanka's landscape of maternal mental health is worse than those initial 1 in 6 and 1 in 5 statistics that I shared. We found that 30% of mothers had depression. More than a quarter, so nearly 26% of the pregnant women reported a lifetime history of suicidal ideas, suicidal behavior, or both. And even more worryingly, 7.5% of pregnant mothers had already engaged in harming themselves in their pregnancies. In a separate setting, also in Western Province, I had established a surveillance system, just like I was saying WHO had been advising us to do. where I identified and then interviewed every man and woman and adolescent admitted to a major hospital for self-harm over a period of nearly a year. And what we found was that about 13% of the women admitted for self-harm to this hospital actually counted as perinatal women. So what that means is that they were either currently pregnant or they had been pregnant in the previous year, whether that meant their pregnancy ended in a live birth, taking a baby home, or in a stillbirth or a miscarriage, and in a very small number of women in an induced abortion. But 13% is no small proportion of women coming into hospital that fell into that category. And so what you can gather from this is that it's actually a major proportion of women experiencing these forms of distress who fall into this category of pregnant or postnatal. So what are the risk and protective factors that I can highlight here? For depression, in the local population, what we found was that actually having a higher education was protective for women. So women who had secondary education compared to primary school only had a significantly lower risk of displaying signs of depression. So there may be something protective about education. In terms of major risk factors for depression, women who were stressed specifically about their households being in debt and their husbands having substance misuse issues were roughly double as likely to have depression. And if their husbands were unemployed, they were 4.5 times more likely to be depressed in pregnancy. So you can see these socioeconomic markers were clearly putting additional strain on women in this period. Really importantly, though, women who had a lifetime history of suicidal thoughts or behaviors or both had a 10 times more likely chance to have depression and suicide risk in their current pregnancies. Intimate partner violence increased the likelihood of suicide risk and depression in pregnancy by 4 times. So women's mental health histories and these life circumstances are really, really valuable pieces of information for service providers like midwives and obstetricians to get as early as possible. Even during fertility treatments, if individuals, couples, families are going through that process, it will help us to know which women may be most at risk by asking about life circumstances, socioeconomic conditions, education levels, and past difficulties with mental health. And finally, I want to highlight that 1 in 5 women who displayed suicidal behavior during their pregnancies showed no signs of depression and anxiety. And the reason that this is really important is that oftentimes we're told the overwhelming majority of people who die by suicide had clinical depression. But actually what we see in Sri Lanka and many other low and middle income settings is that that's not the case. So this is further evidence that we really need to break this myth that we assume that, for example, a woman who engages in suicide in the pregnant or postpartum period was clinically depressed or had postnatal depression, etc. And that's just not an assumption we should be making. So we actually need to be checking with women separately on these issues and not conflating them as the same part of the same issue. So what does this all mean for you all? It means it's not about hormones. This is true for women globally, and it's something that we're sort of reckoning with in the sort of mental health space in the UK and the US and many other settings. Hormones play a very small role in the contributions to women's risk in this period. It's actually really about social support, stability at home, safety more than anything else. And this really matches what we're seeing now in many different settings. And it means that the care women receive during pregnancy, if not before, and definitely afterwards, regardless of the outcome of that pregnancy, is really critical in shaping emotional and mental well-being. And this is something that all of us can take partial responsibility for in our interactions with mothers and mothers-to-be in our lives, or actually just women who are considering becoming mothers. Because maternity care is so important, I did some additional research, and this is actually to my amazement at the time, it's the first research in the world that looked at the role of midwives in managing suicide risk for women in this stage of life. And what we found here is that midwives are already doing this work because they're really trusted sources for women to confide in. But their responses to women coming to them in states of distress can be really concerning. And this is not only because they are really reactionary, often because midwives have not been given the training in mental health that they would really actually like to have, but also because midwives are women raised in the same culture that the women they're supporting are raised in, and they have very sort of gendered ideas about what good female behavior is and what the right way to manage life crises and household disputes, etc. are. And often what we find is that midwives are actually really kind of enforcing that women play this kind of sacrificial wife and mother role to the detriment of their own well-being. And in the face of, frankly, some horrendous circumstances. They're often more concerned with safeguarding women from damaged reputations than they are from safeguarding women from harm from others. And this frequently, of course, then backfires and leads to women's distress getting worse. This is not unique to midwives here. And I should state for the record, I have a remarkable amount of respect for public health midwives in this country. They are the bedrock of this health system. But they hold considerable social power to support mothers, and that means that they can either shield them or they can expose them to more difficulty. So for that reason, what I would suggest all of us kind of collectively think about and find ways to integrate into our own life is ways that we could perhaps advocate for better training and support for midwives in this country. Also from a family setting, to allow companions to be with women for their antenatal appointments and critically for birth. So in public hospitals in this country, still women are not allowed to have any companionship in birth, which is a long, hard fought battle being led by some really extraordinary obstetricians. But we're not there yet. And so those privileges that women get in private sector need to now spill over to women using public sector services. And finally, I'd like to suggest that we find ways to support dads, to support partners to take on a more active role in parenthood, and also all the ways that they can assist women at these really sort of hugely transitional times. So these are all just things for y'all to think about, and then you can ask me additional questions. But that is what I wanted to share from a provider and lived experience perspective from women in pregnancy and postpartum in this country. So thanks for that.
Thanks, Alexis. We have a very interesting question. It's a generational thing. The older generation will say, in our time, we didn't have any of this rubbish. We had babies and we got on with life. What are you talking about? What's the fuss? And somebody's actually said that she's had that experience. Her grandmother has said this to her, why don't you just get on with it, kind of. So what do you do about things like that? Because it's, I think the perception is that now we've got sort of more westernized, and I don't know how they will look at it, but they'll say, we got along with our lives and we had 7 babies and 10 babies and we didn't. What is postpartum depression, So
yeah, so there's a number of things to say to that, and I mean, this conversation could go on forever, and so I just want to point a few things out. For starters, we don't know how many women were dying by suicide in this period before, because nobody bothered to count. So when people say, oh, this didn't happen and we don't know, or it wasn't a problem, maybe it wasn't a problem because nobody bothered to care enough to notice that it was a problem. With the midwives that I've spent a lot of years now working with, who have been in service for 30 or 40 years, they will tell you they were dealing with this stuff 40 years ago in their first placement. So this is not a new issue, right? I think it's a worsening issue in the sense that the pressures on women and on mothers are getting, the bar is being raised constantly, which means the heat is being turned up constantly. And this really, it's actually, again, a kind of Western export, which is really ugly, is this kind of competitive, who's the best mom kind of attitude that we see. And there's so much judgment. You know, when we see poor outcomes in children, the mothers are almost exclusively blamed for those outcomes. When there are successes in children, then fathers get to share. And of course, you know, they've been part of shaping that success. So there's a real burden of responsibility disproportionately put on women, which I do think is getting worse. So I think that's part of it. What I also would say is this attitude of it's natural, you know, it's part of life, it's natural, just get on with it.
Mm-hmm.
Just because something is natural or common doesn't mean it's okay. You know, it's really a huge concern if, you know, if you've got 30% of your mothers-to-be who are debilitated by anxiety about being able to care for this child. It's common, but that's not acceptable. So I think, you know, we need to get away from this attitude that just because something is natural and has always happened, that there's not a problem with that. You know, it also used to be natural to just let women die in childbirth, and we decided that that wasn't something we wanted to see anymore. So I think these are deep-seated attitudes that need to change. It's really hard to change them, and a lot of what's reflected in that participant's comment or question is exactly why we see the sometimes damaging responses from midwives, right? Because they also have some of those views. They've grown up with their grandmothers saying the same thing. So they can't kind of tease apart the culture they've been raised in with the job that they are doing, which sometimes means the help that obstetricians are giving is not favorable, and the help that midwives, nurses, etc., is actually not helpful, if not damaging. So there's a whole spectrum of attitudinal change that needs to happen, and political will for the Ministry of Health actually to change this in that system, at least. If we can't change it in our own social networks, the health system has to make these changes.
Thank you. They've also asked, what is the relationship between a mother's mental health and child outcome? Is that something you want to discuss? Yeah?
Well, so I mean, just briefly, you know, we do know that, you know, that if a woman has really high levels of cortisol, which is the stress hormone that's released in pregnancy, then we often do see in children later, in fact, right the way through adolescence, you know, sometimes more hyperactivity, more externalizing behavior, more aggression, these kinds of things. So obviously all of the chemicals and experiences that a woman is having to deal with is going through the placenta and is part of, you know, this programming process as a fetus develops. And so of course that kind of, if you're living in a really stressful life condition, that's going to translate to your kid. And so, so I think there is a very direct and really rich body of evidence that connects those two things. But the reason why I wanted to make this point actually is, while we know that, of course, poor mental health in moms can contribute to challenges in children, I never, ever want people to then blame mothers for those outcomes in their kids. And that's a really important thing. You know, I often hear perinatal psychiatrists, so they are, you know, focused on women in this period, make the case that because there are poor outcomes in children, then we should focus on mothers' mental health. You know, I frankly don't care if children are born genius unicorns. If it's at the expense of the mother's mental health, we have a problem. So I think sometimes while I appreciate that really strong scientific link, I also want people to understand that we should care about mothers' mental health because we should care about mothers, not just because we should care about what it can possibly do in the future to some children. Yeah.
Okay. I think we can move on. Is there anything else you wanted to address, Alexis, or shall we take it up later? Okay.
Yeah, you go ahead.
Okay. So Thank you very much, Alexis, and we are very grateful for all those insights and for all the support you have given us for this program. I'm now going to move on to our next speaker, who is Nivendra Uduman, a counseling psychologist who has been practicing in Sri Lanka for the past 6 years. He was the senior technical officer at Samutthana, the King's College London Resource Centre for Trauma, Displacement and Mental Health in Sri Lanka, and currently runs his own practice. Nivendra had his undergraduate and postgraduate education in psychology at Christ University, Bangalore. He is the founder of Footsteps to Freedom, where he walked 550 kilometers from Dondra to Point Pedro in 2016 to raise awareness for mental health. And in 2018, with 2 colleagues, he walked 1,460 kilometers around the entire coastline of Sri Lanka for suicide prevention, speaking to diverse groups and disseminating information about the mental health services available in the country. He is also the co-founder of the Community Crisis Response Team, LK, CCRT-LK, which is a group of volunteers trained in first aid, CPR, AED, and psychological first aid, who have been activated in different emergencies in the past. Nivendra has also been involved in providing training and capacity building for health professionals, community volunteers, teachers, and in counseling and mental health. He is a passionate advocate for mental health and LGBTIQ+ health and was awarded a citation for excellence in service in mental health in 2016 by Christ University, Bangalore. He also represented Sri Lanka at the One Young World Summit held in London in 2019 and is an international consultant for International Transport Workers Federation, where he has been involved in developing a curriculum in understanding and managing stress for cadets and seafarers, and has trained seafarers and instructors in Sri Lanka, India, and Colombia. Nivendra will present on how to talk about suicide and self-harm. Welcome, Nivendra, and over to you. Oh, okay. I just see that Nivendra is having tech issues. So what we will do is, I hope we can bring up. Hold on 1 minute. Yes. So I'm going to ask Dr. Fergus Kane to come up and let me introduce him. So our next speaker is Dr. Fergus Kane, a clinical psychologist working for the PICUP Outpatient Psychosis Service at the Maudsley Hospital and the National Psychosis Unit at Bethlehem Hospital. Dr. Kane completed his MSc in Neuroscience in 2004, his PhD in Neuroimaging in 2008, and a doctorate in clinical psychology in 2012 at the Institute of Psychiatry, now IOPPN, King's College London. Dr. Kane's PhD focused on cognition and brain function in people with a diagnosis of bipolar disorder, and he maintains a keen interest in this area. As a clinician, Dr. Kane has worked in 3 different countries, UK, Ireland, and Ecuador. He recently returned from working in Ecuador to work at the South London and Maudsley NHS Trust. Dr. Kane has a specialist clinical interest in working with people with psychosis and diagnoses of bipolar disorder as well as in, I'm sorry, I think we're having technical difficulties. Fergus, can you hear me?
I can hear you fine, yes. Good.
Oh, okay.
Okay, I mean, I've lost you, I think. So I'm just waiting for a question from Rinali. Well, I guess whilst we wait for Minali, I guess I will introduce myself a little bit. And so what we were going to do was a conversation between Minali and I, really about how do you choose a clinical psychologist? How do you trust clinical psychologists? How do you talk to psychologists? I do have a list of Mrinali's questions here, so in her absence, I'm gonna read her questions. Okay, Mrinali, are you here? So just bear with us whilst we fix some technical support issues. I have a message saying Mrinali is back. This is what happens when we do stuff on the internet. Okay, hi Mrinali. I can't hear you. I think you're on mute. Can we unmute Mrinali so I can hear her? Okay, everybody stay with us. It will be worth it. I think the discussion we're going to have is going to be good, especially at the end. Okay, I'm being told that Mrinali is not on mute. Can anybody in the public chat let us know if they can hear Mrinali? Because I can't. And maybe if you're in the public chat, can you let me know if you can hear me? All right, okay. People can hear me, I think. So, well, I guess I'll make a start. So, I've known Mrinali for quite a long time. I used to work in Sri Lanka from about year 2000, running volunteer projects and things like that for about 10 years and ran a charity in Jayala. So I'm quite familiar with Sri Lanka. I'm a clinical psychologist, so my job is to help people with their mental health issues, get them back on track, help them overcome things like trauma, and live their lives the way that they really want to. I also do research to help understand how to do that best. My speciality is psychosis, and I work with people with psychosis and bipolar disorder, but I also work a lot with trauma, which is really important when we're talking about suicide as well. A lot of people who attempt suicide or self-harm may have a trauma background. And so I've got add Mrinali on, please. So I've got a question that Mrinali was going to ask, one of the questions we had as a backup, which is what... hi, Mrinali. Are you there? Can I hear you?
Hi.
Oh, perfect.
Okay. Okay. I'm so sorry for all these technical things, but I don't know. You've introduced yourself, so I don't need to go back and do that. All right. So we were going to talk about how to choose a good psychologist. Did you get into that at all? Did you start on that?
I haven't gone into any details, so I just kind of introduce what I do in the background. So yes.
Okay. So shall we go right into it?
Absolutely.
All right. So I went and I checked online how to choose a good psychologist, like everybody would do, I think. And it said research, research, research. Look for experience, try to make an early connection, check licensing and insurance, and never settle. I'm sure you'll have lots to add to that list, or you'd like to expand on that. But how does one choose a good psychologist?
Okay, so I guess I wrote a blog article on my website about this when I was working in Ecuador, and I think Ecuador has some similarities with Sri Lanka in terms of the fact that psychology is not a very well-developed profession yet. I know there's a lot of efforts to develop the profession and to train, and so there's a limited number of people to choose from who you can work with in Sri Lanka, and the same was the case in Ecuador. So it was given that, how would you find out who was a good psychologist? And there's an issue in terms of qualifications, but mostly I thought the most important issue is whether your psychologist is ethical. Okay, and when you train as a psychologist in the UK, you'll do a section on ethics, and in that section on ethics, they'll talk about confidentiality. And this was a huge issue in Ecuador, whereas psychologists, psychiatrists would sometimes be talking about their clients' personal issues, and they would share those with their friends. And sometimes you'd find a psychologist would be working with a lady, and they would be friends with the lady's mother, and they would then tell the lady's mother what had been discussed in the session. And we're not talking about a 5-year-old child here with whom you're sharing with the mother. We're talking about somebody in their mid-20s or mid-30s or 50s. And then the mother would discuss what came up in the session with her friends, and then everybody would know about it. And that really is the worst thing that can happen in therapy, because you go to therapy for a safe space, a place where you will talk to people and you won't be judged, and you can discuss everything. Any thought that comes into your head, you can discuss it. And that's really important, I think, when we think about suicide, because shame is quite deeply connected to suicide in some cases. And being able to just talk about what's going through your head with somebody helps get those ideas out of your head and makes those ideas no longer shameful or beyond discussion. And your therapist should welcome everything you have to say to them. They might give you some guidance, they might guide you through how to think about those things, but you need to feel heard and supported. So that's really a primary thing, is confidentiality. And any therapist, I think, should talk about confidentiality in the first session. They should say, you know, before anything else, I need to talk to you, I need to say to you, what you say to me is confidential. I'm not going to tell anybody else, I'm not going to tell my friends, I'm not going to tell my family, except if I think that you are at risk of killing yourself, of hurting yourself, or maybe hurting somebody else. And in that case, maybe I will try and tell you first, and then I will have to let other people know as well to support you in your actions. And even there, we brought up the issue of suicide from the very beginning as well, which is super important, because we need to say we're not afraid to talk about suicide. It's not something that I can't cope with as a therapist. If you tell me that you're thinking of hurting yourself or killing yourself, I can deal with that. I can help you deal with that. And by me not being afraid of it, also you won't be so afraid of talking about these issues. And that can prevent self-harm, it can prevent suicidal actions. So that's really important. There's a whole bunch of other stuff, like how do we make sure that people have qualifications that we can check? Are they a member of a professional organization? And we can talk a lot more about that. And I think Sri Lanka has some work to do on developing professional organizations for psychologists that will regulate psychologists. Just briefly, to give an example, if you work in the United Kingdom, you are regulated by an organization called the HCPC, and they will make sure that if you're doing something that's unethical, whether it's not being confidential or having sexual relationships with your patients, which does happen, that you lose your license. And once you lose your license, you're no longer able to call yourself a clinical psychologist, and you're no longer able to do that work. It doesn't work perfectly, but it's really good to have that. So that's kind of a little bit of background, I think. I mean, I think, Mrinali, now you can focus me a little bit.
No, but I think if the psychologist doesn't initiate this confidentiality conversation, I think that if you are seeking some kind of therapy, I think you should, I don't know whether patient is the right word, but whether you should initiate that conversation and say, you know, at the outset, this is one of my sort of non-negotiables, unless it is, as you said, a very serious and endangering situation. And
I would add to that. I would add to that as well, yeah, because, you know, the level of development and the level of teaching, you may have a really good psychologist in the country who just doesn't do confidentiality as their first conversation, and that's fine as long as you bring it back up and they really sign up to it, and you see that they understand, then that's also fine. I don't want to be too extreme on, you know, saying that if they don't talk about that, they're not a good psychologist. That's not necessarily the case.
No, I agree. But where societies are small, and as you say, like in Ecuador, when you talk about people, you can immediately, you know, sort of figure out who. I mean, it's possible. So then it becomes very difficult. So okay, so I hope that will help people find out. Is there can a psychologist refuse to take on a patient?
Yeah,
I mean,
absolutely.
is there a checklist that you go through as well when somebody approaches you, and when do you look at them and think, can I really work with this person?
Yeah, absolutely. So a psychologist absolutely should say no to clients, patient service users. We have different terminology. We can stick with patients for the moment. If I feel that I do not have the skills to work with a patient, I will not see them. It's a little bit more flexible for me in a country like Ecuador, where I might push my boundaries a little bit there because there's literally nobody else who has the skills either. So what I would then do is find a supervisor in England or the UK or the United States or somewhere else who could guide me through this, because it's, in a sense, it's better to have a good supervised trainee like I would be at that stage in this area, have nobody to talk to.
Correct.
So it depends a little bit on what's available, but absolutely we should say no when we don't have the capability to work safely with somebody.
Okay. And what would you say to those people who are reluctant to go to a therapist because of the stigma? There's a lot of stigma. Nobody wants to say that they're seeing a therapist.
Yeah.
And how can we help them to see things differently so that they will be encouraged to go and seek assistance?
Mm-hmm. So the first thing I would say is I fully understand. For me, the first time I went to see my own psychologist, as a healthy psychologist myself who didn't need help, I was nervous. I was worried. I was worried about discussing my innermost secrets with somebody. And I know there's a question a bit later, which is kind of about whether it's self-indulgent or something like that to go see a therapist. It's actually one of the scariest things you can do at the first time you go, is to go tell your innermost secrets to somebody so that they can help you with them. And so it's a very brave thing to do, to go and see a therapist. Once you've done it, you get the experience with a good therapist that actually you'd like to do it again, that it was enjoyable, that it worked, that it made you feel better, that you solved problems in your life with the help of that therapist. So you're more likely to go again. So also, if you want to encourage somebody, the best person to encourage somebody to go to a therapist is somebody who's just had a good experience with a therapist. Other things I would say is, yes, I would say exactly what I've just said. There's no shame in doing something hard to help yourself live a better life. In fact, there shouldn't be any shame in any of these things, but it's what's better, to do something hard to live your life better and to understand yourself better, or to sit at home and pretend that things aren't happening? What is the stronger, better move, if you like?
Yeah, but we are quite a ways from that kind of attitude to the stigma. And you did bring up a question that I really did want to ask you, because when I've been doing some research, I came across this. It was some say that therapy risks encouraging people to wallow in self-pity. How do you deal with those looking for a sympathetic ear rather than a solution? Because I'm sure you must have that as well. I'm sure there is that side of it as well that you encounter.
Yeah, I think I would say a sympathetic ear is incredibly important. A sympathetic ear is what keeps us well. We all need a sympathetic ear in our lives. And actually, before going to a therapist, hopefully you can go to a friend or a family member and you can have a conversation with them. And that's really important. We'd like to, I think, build that up, or a teacher or anybody else in your life who you think will listen to you. We can't solve all our problems in our own heads. We wouldn't expect to do that. We carry a notepad around, we use a computer. We don't expect ourselves to remember everything in our lives. So why should we expect ourselves to solve kind of difficult psychological issues in our own heads by ourselves? We're social animals. So sympathetic ear is super important. And then if you don't have a sympathetic ear in your community, then going to see a psychologist just to be a sympathetic ear is an important step as well. But the psychologist is supposed to add something more. They're supposed to add knowledge of how the brain works, or knowledge of how the mind works. If you've got some obsessive compulsive tendencies, or you're hearing voices, or you're seeing unusual things, or you think you're going to have a heart attack when the doctor says you're not, that's kind of like a panic attack, then your psychologist should be trained in such a way that they can help you deal with those particular symptoms, which a sympathetic ear of your friend is not enough often to do. So I don't know if that makes sense as an answer.
No, it does, because I was a little troubled by that comment, because it might put some people off, and then they might think that you're seeking pity or whatever, and then they may not want to go and seek therapy. Then there was another thing that I read, which said apparently about 60% of people with suicidal thoughts do not seek help. And reasons for not doing so include low perceived need and wanting to deal with the problem alone.
Yeah, so, thoughts on that would be, well, why do we want to deal with the problem alone? So a psychologist will always unpack these things. There might be multiple reasons you want to deal with the problem alone. It might be because of the stigma of dealing it with somebody else. It might be because when you were growing up and you came with an emotional issue, your dad told you, how stupid are you? Why don't you just deal with this yourself? And you've got this now inbuilt voice of your parent, of society saying you need to deal with this by yourself. And again, how many things does society say you have to do by yourself? You can't build a rocket by yourself. You can't run a school by yourself. Why should you do this by yourself? And then there is the stigma. And one of the things I work with people on doing is that kind of stigma and shame. The more confident you are eventually of speaking about these things, then that shame kind of just dissipates because you take a step over it. And that's part of what happens in therapy. You are able to say these things much more easily in future.
Yeah, but sometimes you might be saying things and other people might be judging you. So I think that's a big fear for a lot of people, especially, I think if you're in a working environment, you do not want to show vulnerabilities. So maybe it's not really, sorry? Absolutely,
and that's why you have a therapist, because the therapist is providing you with a non-judgmental approach to your issues. And let's say you have different sexuality, or you have a different religion, or all sorts of different things that people are not comfortable with, then your therapist should be able to see all of that with a non-judgmental eye. And that's very different. You're guaranteed by a good therapist that they're not going to judge you.
Alexis has a comment. It says, depends what we mean by seeking help or telling someone else. In my work here, almost all women disclose to someone, often mothers, midwives, other family, etc. But they were rebuffed and shut down. So then they can't go any further and tell somebody who's unfamiliar to them.
Exactly. So a lot of us learn in what we call one trial learning. We'll try a difficult thing once. If it doesn't work, we won't try it again. So if we had that bad experience with our parents or with a co-worker or with a midwife, we might not try again for 10 years.
Okay. So I hope people are clear on, Fergus, do you have anything else to add? On choosing a psychologist, is there, I'm sure I didn't ask you enough questions to put out what's in your head. So if there's something you want to add, please do.
So I don't normally do this kind of self-promotion, but if you want to read what I've written in detail, I've written this thing on how to choose a psychologist in Ecuador. If you just change Ecuador in your mind with Sri Lanka, it's the same story. I could talk about it for a long time. Everything's in there, plus some links to some other people's ideas as well. I think the best way often is to find somebody who has been recommended by somebody else, and then check that that person also understands your difficulties. Say, have they ask the therapist, have you worked with these difficulties before? Does the particular therapy that you do have a good evidence record with working with this difficulty that I've got? And I've got a list of questions in that blog article, which I can put up on the YouTube post or something like that. And you can read through that, but I think I need to allow time for the rest of our conversations.
No, but I have one more question. And it just left my head. But no, I wanted to talk about the post-COVID, the tools that you developed. I don't know whether you talked about that in your introduction when I was off air. I think that's important, and that might be a good thing to talk about. And the second thing I wanted to ask you is, if you can't find a therapist, say in the country you're living in, say in Sri Lanka, would you advise then looking online for somebody who you could chat with, so that you have sort of say a Skype or a Zoom conversation with someone? Would you recommend that? No?
Yes, with provisos. Absolutely. So, I mean, the first question, yeah, as a result of the COVID pandemic, with some other colleagues, we set up a thing called Help Us Tools, which I can also provide a link to, which was a CBT-orientated group work that you could do with a group of friends or family or people who share some of your values. And you could work through several sessions of that together, and that's free. And we can put a link to that as well. And I guess we'd appreciate feedback as well from how people in Sri Lanka found it. Obviously, it's only going to work for English speakers, so it makes it quite limited into who can actually use it. And there's a lot of tools like that as well. And there's some tools from Australia for self-help in kind of cognitive behavioral therapy, which are really good. But again, they're mostly for English speakers. So I guess if anybody in public chat knows of any good therapy tools in local languages, whether it be Sinhalese or Tamil or whatever it might be, then that would be good to share here as well. So that was the first part of your questions. Remind me the second part of your question.
The second part was whether if you can't find somebody in the country that you're living in, whether you should then reach out online.
So I think absolutely the fact that we can do things online allows a lot more flexibility now. And when I was working in Ecuador, I could do therapy with people in the Amazon who would never come near a therapist. And I could do therapy with people in different countries. There are some potential legal issues there in terms of who's responsible. But if there's nothing available where you are, then by all means, seek out therapy elsewhere. Obviously, it has a cost attached to it, as everywhere. And the cost depends on the country that the therapist is in. So if you can find a good therapist in a low-income country, that's going to be really good. Especially somebody who speaks your language, who shares some of your cultural background. But I would say also, actually, some of my clients in Ecuador were Ecuadorians who rather speak in English than in Spanish because they found it easier to talk about their difficulties in a second language to start with, which was really interesting for me. So absolutely reach out, but again, do the same thing to check whether they're a good, reputable therapist, as I've put in that article that I've shared.
Okay, thank you. We will move on to the video now, Shamil. We will go on and show the video, and then I will interview Nivendra, or we will have Nivendra speak to us, and then we'll go into the panel discussion. Thanks, Fergus. Thank you so much. We'll catch up with the panel. Yeah, thank you.
What's in a smile? A simple smile could mean little to you or I, but to someone thinking about suicide, it can be the first step towards life. Suicidal thoughts are complex. No one knows exactly what works to stop another tragedy, adding to the 800,000 suicides and 20 million attempted suicides a year. We do know, though, that certain actions can make a difference. And we know that if we put a wide range of these actions in place, we have a better chance of preventing suicides. Community support to counter the isolation so often felt. Responsible and sensitive media portrayals to help people see how others have managed. Local education to create awareness in the community. Restricting the means of suicide to stop people at critical moments. All these actions have been shown through research to work. But we can't do all this alone. We need people on the ground to help us make the first step towards those with suicidal thoughts. By stepping closer, we can be aware of those around us who need help. By stepping closer, we can encourage those with suicidal thoughts to reach out. By stepping closer, we can support those in need by sitting in their pain. Every step closer can connect someone to life and the help they want. Sometimes those steps are big. Sometimes all it takes is a smile.
Okay, so that was the video from the International Association for Suicide Prevention. We thought we would share it with you, and it was, thank you, Alexis, for pointing it out to us. I'd like to invite Nivendra now. Nivendra, I'm so sorry we had this technical glitch when I was introducing you. I hope I said all of it. I think I stopped when I was talking about you attending the Young World Summit held in London in 2019, and that you're an international consultant for the International Transport Workers Federation. Could we have Nivendra on, please? Hi, Nivendra.
Hi, Minali.
Please talk to us about suicide and self-harm.
Sure. Okay, first of all, thank you for all of you for being here this evening and taking the time to join in. And also thank you to the British Council Sri Lanka for facilitating this conversation. So when we talk about suicide and self-harm, especially in a context like Sri Lanka, I think one thing I want to start with saying is that in mental health, in health in general, there are some things that we are more comfortable talking about than other things because of one is, of course, the stigma that exists around it, but also very negative societal attitudes, beliefs, and also a lack of understanding and education because we don't receive that sort of education in our system in this country. So therefore, in the current kind of discourse around mental health and what we've seen in the past couple of years, there's a lot of conversation going on about depression, about anxiety, about stress, but not so much of conversation about serious mental illness like bipolar disorders, psychosis, personality disorders, trauma, and of course, suicide and self-harm. So we see a lot of Instagram posts, Facebook posts, things like that on depression and anxiety and stress and all of that, but we don't talk about this stuff a lot. So I think it's important that we start that conversation as well, because mental health is not limited to just depression and anxiety, even though that might be the most common thing that we might experience. So this negative attitude around suicide and self-harm, I think a lot of the time is perpetuated in our country and in our region with the language that we use. That is one thing we need to talk about. And that is also perpetuated by people who are supposed to be kind of sensitive and knowledgeable about this area, like health professionals, who often stigmatize survivors of suicide attempts and people who are having suicidal thoughts further by the insensitive language that is used. So for example, internationally, we are having a lot of talk around not using the word committed when we talk about suicide. So all these years, we've been used to using the word committed suicide or the phrase committed suicide. But as of late, there's a lot of talk going on around how that can be quite difficult for people to hear when we use the word, and how that could also prevent people from really accessing support, talking about what they're going through with someone. So what I want to say is that instead of using the phrase committed suicide, it's important that we use something like died by suicide, or the person took his or her own life, right, or ended his or her own life. So also there are no successful or unsuccessful suicides, because that gives us this notion that it's either, it has to be so black and white, but suicide is not black and white. There's a lot of gray area in the middle. So it's important that we try as much as possible not to use that kind of language, but to use things like an attempt or a non-fatal attempt, or we just can say, again, died by suicide. And also not to refer, because again, how we talk about self-harm and suicide in the public kind of discourse, in the media, in schools, in families, in our own homes, affect how we would approach someone who might need support. It affects how we might ask that question from someone who might be at risk. Or it also affects people reaching out to us and opening up based on simply the way we talk about it. So also when it comes to self-harm, recently we've seen this shift in a lot of other countries around the world, where we are just using the phrase self-harm rather than deliberate self-harm, because the word deliberate can also have a lot of weight on it. It can be difficult for people to digest, right? And I mean, the reason deliberate was brought into the picture was to separate kind of self-directed violence, like Alexis spoke about earlier, with accidental harm. Which is why in Sri Lanka, in the medical sector, a lot of people call this deliberate self-harm still. So I think it's important that we try not to use that phrase, but just to say self-harm, right? Because self-harm doesn't always have to be linked with the intention of suicide. Right. So another angle to this is how we perceive people who either are having suicidal thoughts or ideation, or people who have had thoughts in the past, or people who might have also attempted suicide. So we see in the public sector a lot that there's a lot of a very negative attitude and stigma around this, especially also in the public hospitals where attempt survivors are often brought in. So you hear a lot of staff in these medical institutions saying, you know, oh God, it's a time waster. They're wasting our time. And I have friends who have been attempt survivors, who have been hospitalized and have been told, you know, you don't deserve a bed because you just wanted to end your life. So you just might as well suffer a little more until we can treat you. So these are real conversations that people have had with attempt survivors. So I think while we are having this conversation to sensitize ourselves, but it's also important to really look deep into ourselves and ask ourselves what kind of attitudes we hold about people who may have attempted suicide or who have thought about suicide. So what I want to do now is to kind of look at how we as a community, not as professionals or psychologists or anyone else, but just as people, how we can broach this conversation with people, how we can ask about self-harm and suicide from friends, from family members, from colleagues, if we think that they may be at risk. And also just generally how to have conversations around emotional well-being with people. So, for example, I think one of the priorities is for us, if we think that we are concerned about someone, that we need to approach and talk to them, or if someone reaches out to us, which also happens, it's important that we connect with this person in a very personal way. So not in a mechanical or a clinical way, but in a very personal way, in a warm manner. And also let the person know that we are 100% available to listen to them, to be with them. And a part of this is also us being okay with silence, which is something a lot of us find difficult to do. Because we sometimes, to quell our own anxiety, we might talk a lot, or we might text a lot if we are talking to someone, which might prevent the other person from opening up. So sometimes if the other person is silent, if the other person is maybe not talking at that time, I think it's completely okay to just sit with them, let them know that you're there, and let them know that you're there to listen when they're ready to talk, and not to hurry people or pressure people to tell you their story. So connecting in a personal way and just asking them questions beyond how are you, because we all know commonly that when you ask that question, a lot of the time the response is I am fine, because that is kind of thing we are programmed to do. So it's important, I think, to ask questions beyond that, to ask questions about how they're feeling, ask questions about whether they're experiencing any form of crisis in their lives at the moment, or whether are they feeling hopeless. So those are the kinds of questions that we can ask, and we shouldn't be scared to ask them, because in our society there's also this notion that are we being too intrusive, are we invading in their personal space by asking these questions or starting these conversations. And I would like to say that we need to really get that misconception out of our head, because when we ask questions directly, when we ask questions genuinely from people, it's important that we don't kind of succumb to those misconceptions. And when we ask directly about things, you often receive answers from people. So having said that, so you connect in a personal manner, you ask them about what's going on in their lives, right? And you give them space to talk. We don't hurry them or rush them. And it's important that we also remain calm when we're talking to them, and we don't get worked up emotionally because they may be talking about stuff that is difficult. So in this conversation, if you think that there is a risk of this person maybe having thoughts about suicide, or having maybe a plan to attempt suicide, or there's been some history in the past, it's really important that you are able to ask the question from them. So not just about suicide, but also about self-harm, right? So I think lately I've been seeing in certain research articles or in certain things that other clinicians have been saying and in books that I've been reading, that it's important that we take a very compassionate approach in asking this question, right? So there's a certain school of thought that says, just bang on, ask the question, are you thinking of killing yourself, or are you thinking of suicide? But there can also be a compassionate approach to this, where you can say something like, for example, let's imagine that you have a friend who is going through a relationship breakdown and is talking to you, and you might have the concern about whether there is a risk of them thinking about or attempting suicide. So you can say something like, sometimes when people go through difficult things like a relationship breakdown, they can sometimes feel like life is not worth living anymore because it's just too painful. Have you been feeling this way lately? Is a caring approach to asking about suicide, right? And if they answer with an yes to that question, or if they give you the indications that they have been considering that, or they've been thinking about suicide, then we can follow that up with a more direct question asking, okay, are you having thoughts about suicide at the moment, or have you been thinking about suicide? And then if they say yes to that, or if they indicate that there is a risk, it's important that we also ask them, okay, have you thought of how you'd want to end your life if you were to, or have you made a plan as to how you'd want to end your life? So it can feel really scary sometimes for us to ask these questions because we're not used to them. We've not been taught how to. And also there's a lot of myths around talking or asking about suicide, because we believe that we might be putting ideas into other people's heads, or we might be kind of nudging them into actually attempting suicide by asking them that question. So there are also lots of health professionals in this country who avoid asking that question, or who are not comfortable asking that question, for the simple reason that they believe that this person might be really more kind of convinced to take their life, or they may develop thoughts that they don't already have. But what I want to say is, and I say this over and over again for everyone, not just professionals, we need to be comfortable asking this question. Because not asking this question from people, not just in a healthcare setting, but just as friends or family, we are giving the person the kind of underlying message that we'd rather not know, or we don't want to know, or it's too much for us to know. I can't handle it if you tell me that it's a yes. That is one reason we most often don't ask, because we are afraid that we might not know what to do after that, or we don't want to take that responsibility. But what we have to understand is that you don't have to bear that responsibility alone if someone does disclose to you that they are having thoughts about suicide, or they have been thinking about attempting suicide. So it's important that we don't have to bear that burden alone, or that keep that information to ourselves, but we can always share that information with having told that person with someone who is responsible. For example, it could be a family member or another close friend, or even a healthcare professional if that person is seeing someone, a therapist or a doctor or whoever it might be. So it's really important that we do not promise confidentiality as a friend or a family member to someone we are talking to, because very often we might be tempted to do that, to say, don't worry, I won't tell anybody, you can share whatever it is with me. But in this case, it's really important to also make it known to them that you might have to share this with someone else in order to keep them safe, because you care about them. So sometimes you can have slight reactions of anger or feeling a little irritated with you when you say that to them, but try not to take that personally, because it's about that person's safety and that person's well-being that we are talking about. So having gone forward from asking the question, it's important then that we kind of look at how we can keep that person safe until maybe that person can get some professional support, or if someone else can intervene. So I think one of the key messages is to try to restrict their access to means, right? So what that means is anything that they can use to harm themselves or to attempt suicide, it's important that we try to keep them away from those things. That's number one. And number two, I think it's very important that we don't leave them alone. So having someone with them just to check in on them, but not being intrusive or always in their space, but not leaving them alone either, because that is something that can put someone at risk if they are alone while having suicidal thoughts or being distressed. So not leaving them alone, keeping them away from means as much as possible. And I think also kind of helping them not use alcohol or other substances at that time, because that can also intensify a lot of things that they might be feeling and makes the situation worse for them. So those are a few things to keep in mind. And I think you can also share with them crisis hotline numbers that are available in Sri Lanka. I think maybe we can put it up on the public chat also in a bit, but I'll just share those numbers with you. So one number is 1333, that is 1333, which is a 24-hour line. There's also Sumitra, which has a number, which is 0112696666, which you can access from 9 a.m. to 8 p.m. every day. And there's also the National Mental Health line, which is at the National Institute of Mental Health, which is 1926, which is also accessible 24 hours. So these are numbers that you can also share with people for them to get support over the phone until they can actually meet a mental health professional. So it's up to us also to slowly, gently, kindly encourage people to seek professional help as much as possible if we know that they are in distress or they are having thoughts about self-harm or suicide. So just to kind of wrap up, I think two things really that we can take away. One thing is to be very sensitive and conscious about the language that we use when we talk about self-harm and suicide. Even on social media, if you're writing stuff or if you're putting up posts, right, to be very sensitive about the language that we use, and not to say things like it's stupid, it's selfish, or it is something really shameful or weak to do, or people who have only weak personalities might think about suicide. So just to avoid that kind of narrative. And also when we are talking about self-harm, not to use things like a cutter or someone who's manipulative or someone who's just asking for attention, because that is not helpful at all for people who might be struggling, right? So that is what I really wanted to share with you, because I think as a community, if we are responsible, if we kind of break that barrier about using certain words or asking certain questions or having these conversations, I think we can contribute to preventing suicide, because it's not just up to the state sector or the mental health professionals to do that. I think it's all our responsibility as human beings to prevent suicide, and we can by simply taking these first preliminary steps and then recommending that they seek further support if necessary. So thank you, and I'll be happy to take on any questions if there are.
Thank you. Thank you, Nivendra. That was really, really very Have I disappeared again, or can you hear me?
I can hear you. Yeah.
Okay. Can you hear me now, Nivendra?
Yeah, I can hear you.
All right. I don't know. Today we're having all sorts of technical problems. What to do? But thank you so much. That was really informative.
You're welcome.
Can we have everybody? We'll get everybody on board, and then we'll take some questions. Is that all right? Till we have Shamil set up the panel, I would like to ask Nivendra one question. Nivendra? Okay.
Yeah.
Hi. But this one, actually, I thought I should ask Nivendra, because, you know, you were saying, people say, how are you? You say, I'm fine. And you're not fine. But, you know,
Yeah.
you're totally compelled to say, I'm fine. Because if you, I mean, I've tried this out. I've actually said to people, I'm not having a good day, you know. And you must see the dismay on people's faces, because they don't know what to do with you. So that is a big social change that you're going to, I mean, that's a big social change for us, you know, because everybody says smile, like, you know, show your laughter, but don't show your pain. So how do you talk to young people about that?
Yeah, I think, see, there is a broader conversation that we have to have where this education needs to start when a kid maybe first starts school or even before that, where we need to teach children about emotional intelligence. We need to teach about empathy, about kindness, about respect, and mainly about self-esteem. So not having that foundation in our system, we can't expect change like this to happen overnight as adults, because as adults we've been conditioned for years and years to function in a certain way, right? Even though so we know that our brains are pretty plastic, we can unlearn and relearn stuff, but because this conversation is pretty new in this country, it is not so, we've not been having this for a long time. So therefore it's a bit challenging for people to just suddenly change the way they respond, or to be comfortable with difficult emotions in people they know, right? Or to be comfortable hearing those words, I'm not okay, or I'm going through something difficult. So, and not having these awkward sniggles and giggles when you hear those kind of things, but to be personally connected with that person. So I think we need a shift, Minali, from early education. We can't, there's only so much we can do by educating adults or educating kind of adolescents, because we need to start in school. So this is a debate and a conversation we've been having for such a long time to try to push people to include this in the curriculum, which we not still managed to do so much, but there's a little bit of progress. So I think to answer your question is that we need attitudinal change that starts at that age when a child is 4 or 5.
Alexis, and thanks, Nivendra. But Alexis, I saw you nodding. Is there something you would like to add to that, or Fergus?
Yeah, Fergus, you go ahead.
Yeah, okay. I hope the plane in the background isn't making too much noise. I mean, I think actually I've just been distracted and I've forgotten what we're talking about.
About sharing that you're not fine. What language do you use?
Was a few years ago, I decided that I was going to stop saying "How are you," and I was going to say, in the old-fashioned sense, "Good morning," "Good afternoon," "Hello," because we're actually not using "How are you" as a question. We're using it as a greeting. I don't think everybody needs to stop saying it, but we have to distinguish between making a space for a conversation, which needs to be done carefully and at the right time, and not just as you're getting in the lift, because of course by the time you've said, oh no, it's a miserable day, and seen the shock on their face, they're leaving in the lift. So I actually made a deliberate effort first to do exactly what Minali said and just tell people the truth in the lift, just for an experiment, and then to say, okay, I'm not going to say how are you, I'm going to say good morning, and then I'm going to find a time, if I think a friend of mine is struggling or something, to sit down and say, how are you? Like, how are you doing? Like, I've noticed that you seem a bit down or something like that. And reflect on what I've seen and the fact that I think that they want a space to talk about something, and then to try and make that space properly. That's what I wanted to say on that.
Alexis?
No, I think that's a nice response. And I was thinking very much along the same lines. It's actually a real Americanized expression to just greet everybody with this, hey, how are you? And no one ever waits to hear what the answer is. So I actually was thinking exactly what Fergus was talking about. So thanks, you read my mind.
Okay, and the other one was, Alexis, you were talking about, the men and women, and that men actually complete suicide more than women. I think women tend to attempt more. I think they tend to have more cries for help, but I think men tend to actually complete it, and I think maybe that's contributing to the it's almost 2 to 1, isn't it?
It varies.
Sorry,
It varies setting by setting. So in the UK, you'd have a ratio of sort of 3 to 4 male suicides for every 1 woman who dies by suicide. In Sri Lanka, when I started my work here, it was about 1.5 men to 1 woman, and now it's kind of headed in a more disparate direction, where it is closer to sort of 3 men to one woman. But I think the problem, the reason I don't like sort of focusing on the suicides is because it means we're too late, right? There's all these moments before people choose to do this where we can actually intervene. And, you know, IASP's video, you know, really succinctly suggests it can be as simple as just being kind to someone that can change their mind on that day in that moment. So I think we shouldn't underestimate kindness, for starters. But yeah, I mean, I think when it comes to women, I actually quite dislike the phrase "cry for help." And Fergus may feel different. You know, Fergus, you had mentioned earlier you might be able to pick up on this and talk about it. I absolutely abhor the phrasing of attention seeking, because the reality is that, of course, that's what they're doing. They are seeking attention. Quite literally, that's what's happening. But I don't know why we use it in this really sort of negative framing. If someone is selecting to do something this extreme to express that they are struggling, then my goodness, give them attention, you know, rather than thinking about it in this really negative way. So you know, Nivendra, you did a really lovely job at sort of talking us through all of these new alternative ways we can talk about things in a much more dignified fashion for people. But you know, men are often told don't show any emotion except anger. That's a very acceptable one that men are allowed to express in this culture and many other cultures. Women are not allowed to be angry, which is also a problem. And suicide in this country and self-harm in this country is actually really deeply tied to the suppression of that emotion in women over their whole life course. So you know, I think in terms of these discrepancies, almost every man who ends up dying by suicide, there were multiple points to intervene. Almost every opportunity when a woman gets to some point on that spectrum, even if it stops short of death, again, there are multiple opportunities. So it's not me trying to raise it as sort of pitting men and women against each other, but just noticing these differences and recognizing that for both groups, there are plenty of chances that we can help someone make a different choice.
Thanks, Alexis. Fergus?
Yeah, I mean, I think Nivendra had his hand up.
No.
Sorry.
No,
Okay.
You're good to go.
Yeah, I had a couple of thoughts there. So yeah, the attention seeking or the cry for help, it makes an assumption about a behavior. So the same behavior can have two different or multiple different reasons behind it. So we try not to make those assumptions. And in therapy, I often say, like, you know, a lot of my patients, clients, they're mind reading. Oh, he doesn't like me, she doesn't like me. And the only way I can know actually what's happening in somebody else's mind is to ask them. If I don't ask them, I don't know why they did something. And so we talk about somebody who whatever the phraseology is, completed suicide, somebody who's dead as a result of suicide. We actually don't know if they wanted to kill themselves, as Alexis said earlier, or if it was that they were trying to relieve emotional pain and they killed themselves by accident, essentially. So we don't know those things at the individual level. We could have an estimate for what they are on average, and it still doesn't tell you anything about this person. So I also don't like the use of those phrases, and as Alexis says, they're used in negative ways and the ways to dismiss people. If somebody is attention seeking, they need some attention, and they need some compassionate, kind attention, not to be dismissed, which is the opposite. And of course, if they are actually self-harming to get attention, and then you don't give them attention, they're more likely to self-harm again, and perhaps more severely, and potentially kill themselves by accident. And so you don't want any of that to happen. So you want to take everything seriously and give people what they're looking for, which is, I don't know exactly what it is because you have to find out from the person, but probably some kind of compassion and care and meaningful attention from somebody. And so that's really important. And of course, if you don't do that as a medical system, if somebody completes suicide, then all of their relatives have an increased risk of self-harm and suicide as a result of that. The statistics are fairly clear on that. So as a medical system, it's also a logical thing to do, even if you can't manage the basic empathy in the medical system. And it's interesting how medical systems sometimes can't manage basic empathy as a system, even if the people within it are all decent people. I wanted to also bring up something that Alexis mentioned, which I thought was really interesting. She talked about how if you were a woman and your male partner or husband had an alcohol or drugs problem, your risk of, I think it was self-harm, was increased by about 4 times. I'm not quite sure what the actual statistic was, but that says something, that the woman's self-harm is not a female issue, it's not a woman issue, it's a social issue. In this case, it's actually the man's difficulties are a major factor, I hesitate to say cause, but a major factor in this woman's self-harm, and that probably tells you something about the mechanism that's happening there, and that's really important. And that, I think you can frame that, it brings us all together. It's not about one person, it's about that person's network and friends and family, and often their close domestic network is the thing that's driving some of this behavior. So yeah, that's the kind of things I wanted to say.
Nivendra,
Yeah.
did you have something you wanted to add?
No, I just wanted to say also that we have to, especially in this context in Sri Lanka, we have to consider societal inequalities and aspects like poverty, other social issues, gender, like Alexis spoke about earlier, but also our history of trauma as a country, and we are a country that has experienced collective trauma. And while we have a collective sense of resilience as well, but we are a traumatized community. We have to acknowledge that, whether we like it or not. All of us, and even though some of us weren't born in that time, sometimes we know that trauma is carried forward from generation to generation. So I think we have to address that as well, the role of trauma as a country, but also role of the trauma in the life of the individual as a risk factor when we talk about self-harm and suicide. And also, just the way we live as people, the way we live, because even though we like to call ourselves a collective society, there are also aspects that are becoming very individualized and people who get isolated as a result of that. So we have to kind of look at how the age is also taken into account when we talk about suicide. So generally we focus a lot on young people. We talk a lot about how to prevent suicide in school-going children and then young adults, but we also have to consider middle-aged and the elderly population, because we have quite a significant geriatric population in this country and a fast-growing one, and they have their own challenges, right? So I think we have to have a multi-layered approach, and like Alexis mentioned earlier, we can't just prevent suicide by restricting access to means and just having awareness programs over and over again, but we also have to have systemic changes as a response to this.
Okay. There are some comments in the chat. One says, I know many people, especially youth, who are unable to continue with therapy. Okay, this is going in a completely different direction. Who are unable to continue with therapy because they cannot afford the 7 or 8 sessions. Is there any advice panelists can give people who are in such situation?
Can I have a go at answering?
Yes, please.
Yeah, so this is not uncommon in Sri Lanka, because therapy, we have to acknowledge, is expensive, especially in Colombo, and it's basically Colombo centered when you talk about psychotherapy, right? So it is expensive, and there's no regulation, like Fergus said earlier. We don't have a regulatory body per se that regularizes how therapists can charge and so on. So there's a whole wide spectrum of ways that people charge for therapy. So I think to answer that question, if people do have difficulties, and that is a very real concern to have, first step, I think, is to talk to your therapist about it, right? To be open about it and say that there are financial difficulties and it's difficult to keep coming for therapy. And then if your therapist is someone who is empathetic, who is sensitive, that person will also be able to make some adjustments or to see how you can work things out, because you can have a sliding scale on how you charge. But so that is in Sri Lanka, but in another country it would be a different scenario, I imagine. So
yeah, so if I kind of comment on that, I mean, every therapist has their own way of charging. In Ecuador, I did therapy with the kind of elite and used that income to do free therapy with other people, or very reduced price therapy with other people. Now, I was actually privileged to be able to do that because I have other sources of income. I come from a first world country, so I wouldn't judge another therapist who never did that, because they have to have an income as well, and they have to pay for their family, and they deserve an income like everybody else. So everybody's got their model, everybody's got their position. So that's the one thing. Yeah, absolutely. Like, the therapist hopefully will be able to make some accommodation for you. But I mean, it brings a bigger issue, which is that right now in places like Sri Lanka and in all countries around the world, actually affording to provide everybody with therapy is I'm not going to say, well, I'm going to say maybe a pipe dream. It's very difficult to do. So it needs to be done at a community level. And we need to look at ways of getting psychological therapy into the system so that teachers can have conversations about emotions, all the things that Nivendra talked about earlier, really. That these ideas, this privilege that we have to have been educated in clinical psychology and to have picked up on decades of research by really good psychologists, other people don't have, the teachers don't have, the Sri Lankans don't have. This is a privilege that I got through where I was born, partially, and the social status that I had that enabled me to go and choose this particular job, and be able to do work for free and things at the beginning. So I think that as clinical psychologists, there needs to be some outreach by all of us to teachers, to firemen, to policemen, to parents in maternal mental health, like Alexis is doing. And actually, some of the more detailed interventions that we do will become unnecessary for some people if they have earlier intervention, especially for suicide prevention. Stuff that Nivendra was talking about, being able to have a conversation about suicide and self-harm is something that a teacher can do. It's something you can do with your friend. And that's what people are trying to roll out with kind of zero suicide type initiatives and things like that. And I think that's really important because we're not going to be able to get everybody in 16 sessions of CBT, not anytime soon anyway. Or maybe computerized therapy. But, yeah.
Sorry, just to add to that, because I think it raises the challenge of socioeconomic circumstances for people. So Nivendra has pointed out that, of course, at the moment, psychotherapy is very Colombo-centric and hasn't sort of penetrated the rest of the country. What I would give the Ministry of Health credit for, and the Directorate of Mental Health, and definitely WHO Sri Lanka, which has been really critical in leading a mass decentralizing process and a sort of reimagining of what mental health could look like in the state sector. So over the last 10 years, we started out with a sprinkling of these medical officers for mental health in each medical officer of health area around the country, which of course is our sort of lowest level of health service organizing system. And so beyond Colombo, that's the nexus of providers which communities rely on. Midwives, of course, are the foundation of that. And then you have these specialized medical officers in different areas. And so now every MOH area around Sri Lanka, I think, they now have a medical officer for mental health. So these people are community physicians who have had booster training in mental health, and they at least can be in the MOH office running a clinic, seeing people for sort of common mental disorders, common issues, and then they can signpost you onto other services if they think they can't manage it and you need to be signposted onto a higher level specialist. So these things are new, they're finding their feet. Obviously, there's going to be room for improvement. We need to invest in evaluating these services to see where the issues are, particularly still around attitudes, and who is taken seriously and under what circumstances, etc. But I think it's a start. So communities around the rest of the country are going to see more of a presence of mental health as part of the healthcare system. We just have to keep that pressure on and expect that we get political commitment from the Ministry of Health and higher up the chain, that more money goes into this area so we can keep expanding those resources.
Thank you, Alex. because you addressed a question that was in the chat. There was a question saying, how can people be empowered, especially in low social strata and remote settings, to seek psychological? So I'm very happy to hear that, there is a mechanism now and there is a system in place. So it's not just Colombo-centric anymore. There is another one. When a healthcare professional makes the risk assessment that their client is at risk of potential suicide attempt, confidentiality is broken by contacting next of kin. So about that earlier, but only next only there's an extreme case, right? Only if you think this person is in imminent danger. So,
yeah, I think you're breaking up slightly, Mrinali. I think also Nivendra kind of answered that a little bit in his talk.
Yes.
But yeah, we only break confidentiality if we need to do so for the safety of the person or somebody else. And that's kind of a last resort. We do everything else we can first, and then we would do that. And in my case, when I do it, I try to let the person know before I break confidentiality, if it's appropriate, or if not, then afterwards. So I will at least give them feedback that I have broken confidentiality, so they won't come back to another session of therapy and something's happened behind their back. So we do that for the safety of the person. I very, very rarely have to do that, fortunately. But it depends what service or what kind of people you're working with and what kind of difficulties they have. But it's rare.
Yeah, and I think
Sorry, yes. Sorry, go ahead, Nivendra. Sorry.
Yeah, I think another issue here is that a lot of people fear hospitalization when you disclose thoughts, because this is something that we see a lot. It happens. It's not like it doesn't happen, but I think we also have to make clear that hospitalization is not the only solution or thing that we can do for people who might be struggling with suicidal thoughts, but maybe there are so many other things we can do before that. Even as therapists, we see that as a kind of a last resort, right? Because there are so many other things that we can do before that. So I think I want to put that across as well, because a lot of people believe that soon as they say something about suicide, then it's hospitalization, especially in Sri Lanka.
Yeah, and actually, if I just clarify that a bit as well, it's perfectly okay to have suicidal thoughts. There's no reason you need to go to hospital to have, if you have suicidal thoughts. Loads of people have suicidal thoughts quite a lot of the time, and there's not space in hospital for everybody who has a suicidal thought in hospital, even if we wanted to. And actually, what we look at as a clinician, and this is where there's a gap between family and what they're expected to do and a clinician, hopefully, because we don't really want families to have to do all of this stuff. They should have people to support them. We'll ask, do you have a plan? How likely is it you think you're going to do this? Have you tried? Or we'll assess the risk in a lot more detail. And if somebody just has thoughts, they can say to me often, I would absolutely never do this. My religion says I can't do this, or I wouldn't leave my cat alone, or my children alone, or my family alone, and I will be pretty confident that this person is not going to try and kill themselves, because they have a history of not doing it despite having decades of thinking about it. And then we just support around the thoughts. It's not a crime to have a thought, I think is really important.
What side, I just want to address, I know, Nivendra, we talked about the elderly, but if parents were to be vigilant, because we hear about a lot of young people and a lot of blogs and things on YouTube are by very young people. What signs can parents look out for? And, if they think their children are unduly sad or showing depressive tendencies, what advice can you give parents? Like, what should they be looking out for? How should they be approaching this?
Yeah, I think that's a very important question. Signs-wise, there's a whole range of things that people may kind of display or show if they're at risk of suicide, or if they're going through something that might include suicidal thoughts as well. So I think one thing is parents can look out for is kind of changes in behavior. So if a child who is normally not agitated or irritable is suddenly showing signs of being agitated, being more anxious than before, or feeling more irritable and snappy with people. So that is something that we might want to look out for. And changes in mood, where a child who was very active and involved in day-to-day activities in school and etc. is suddenly withdrawing, is suddenly complaining, saying they don't want to go to school. And especially in Sri Lanka, we find that there's a lot of kind of what we call somatization. So it kind of the body being used to express difficult emotions, because sometimes vocabulary in local languages doesn't allow us to be descriptive of what we're feeling, right? And a lot of the words for emotions that we have are pretty technical in Sinhala and Tamil. So for children also, because we don't talk about this stuff in school or at home, it can be difficult for them to express. So they can then therefore convert that into bodily things and say, commonly people say, I have a stomach ache or I have a headache and I don't want to go to school. So parents need to just not stop by addressing the stomach ache, but parents need to also kind of go beyond that and see whether there is anything that is going on. So it could be things like bullying, it could be harassment at school, it could be the child going through abuse in school, or maybe on the way to school. So there could be so many reasons as to why they might withdraw, why they might want to isolate themselves a little more. So for parents to be vigilant around those things as well. And now we also have the added kind of pressure of cyberbullying and cyber exploitation that we need to think about as well, especially now as with the pandemic, because we saw a lot of online schooling happening and now people are slowly getting back to regular school. But there is an increased risk of exploitation online, which can also lead young people to have thoughts about self-harm or suicide. So parents need to watch out for that stuff as well. And I think in my experience, a lot of young children would now also talk about saying that they want to maybe kill themselves, or they don't want to live anymore, or they just want to go. So people might say things like that. And children, we often believe it's only adults or like old adolescents who might actually verbalize these things, but now we also know that younger children are verbalizing these thoughts out loud in school and elsewhere. So for parents to be able to pick those things up, and with adolescents especially, to also keep an eye on social media, because a lot of that content would go up on social media as well. And also around how adolescents and young children use social media, because that can be another area where they can experience low self-esteem, bullying again, and other issues. So it's important that we watch out for that as well. And then changes in sleep, changes in how they eat, in whether the patterns have changed. So those are some things that might tell parents that there's something going on. Not necessarily them having suicidal thoughts, but them being distressed or them being going through something. So it's important for parents to start that conversation with the child at home before they think about taking them to see someone. Yeah.
Fergus is busting to say something. Yes, Fergus.
Yeah, go for it.
I'm just reflecting on my experience of listening to Nivendra's answer, which is a great answer, but it makes me think how hard it is to be a parent, because there's so much stuff there, and so many possible signs, and so many possible issues, and social media, and all sorts of things to panic about. And I guess at the heart of that is trying to find a place, and it's not always possible with every child at every stage of their lives, but to have a place at least feels they can come and have a conversation and tell you that something's happened to them, tell you that somebody abused them on the way to school, and you're going to believe them and believe everything that they say. And often that's not what happens with parenting, especially in more traditional parenting. And it could be that couldn't have happened, that wouldn't have happened at school, that kind of thing. It's really believe what your child is coming to you with, and make that open space from the beginning. And it's never kind of too late to start. Many of us weren't brought up that way, and therefore we don't know how to do that, and we can learn. And thinking that really also networks of parents who can talk to each other about this stuff, because my desk is going up and down. Networks of people you can talk to and have support, because Nivendra's answer is great, and it highlights how much I think parents need support in supporting their children as well. And we have this idea of the village society of the past. I don't know if it ever really happened where the village was all supportive and nice and you could have these conversations, but that's kind of what we want to encourage, I think, is a place that everybody feels supported in supporting other people, because carers really need support in order to support well.
Okay. One final question before we wrap up, because we are we are to time. What is the difference between the role of a clinical psychologist and psychiatrist in treating any mental disorder of a patient?
Nivendra, you want to do it?
You go for it, Fergus.
So, it's a good question. It's a really good question. It depends a little bit where you are. There doesn't have to be a difference. So a psychiatrist can theoretically do therapy if they're well trained in therapy. But essentially, the stereotype is that psychiatrists will help you with your medication. They may prescribe antidepressants. They may prescribe anti-anxiety drugs, whereas psychologists will do the talking therapy and the family therapy and those kind of interventions. One of my concerns working in Ecuador is that the more old school psychiatry hasn't kept up to date. And so some of the bad practices that we have exported from the UK and from the USA and from Canada have not been updated in some other countries. So, for instance, a benzodiazepine is a drug that's very, very rarely supposed to be given for more than 4 weeks. And it leads to addiction and all sorts of other problems. And it's really effective in reducing anxiety in the short term, but it maintains anxiety in the long term. So the psychiatrist will prescribe you medication, and the medication can be really important to get you to have sleep so you can even do therapy in the first place. But at the same time, you have to be really careful picking your psychiatrist as well. And sometimes in Ecuador, people thought the good psychiatrist was the one who just gave them the benzodiazepines quickly, and they felt relief quickly, and they felt better. But the good psychiatrist is the one who gives you the medication, monitors it, asks you about your side effects, takes your report of your side effects seriously, and maybe works with your psychologist in kind of helping you manage your own medication. So it's just as important to pick a good community-minded psychologist, and not necessarily the one with the most certificates or the best university behind them, but one who's got a good reputation for really managing things in a holistic way. So that's kind of my answer.
Anyone else has anything to say before I wrap up?
I think all I would say is that they don't necessarily need to be competing with each other, and you don't have to make a decision to see one or the other. And that oftentimes, really good psychiatrists will actually suggest you should have a counselor, you should have a therapist. And simultaneously, if you go and see a therapist and they say, look, I think, you might benefit short term from some psychiatric medication, etc., then you can go, they might advise to go see a psychiatrist as well. So I think they don't need to be competing entities. I think part of the reason that it feels like that is because that division is created by the profession. But we have a choice as service users, clients, whatever, to say, I'd quite like to explore both, or I don't, what's better for me? And we have a right to ask those questions, particularly as Fergus is raising super important points about medication, which, that's possibly a session for another time, but it's really important. So, yeah.
Yes, Fergus?
I don't want to say anything else more other than I haven't been to Sri Lanka for about 10 years. So after working on and off in Sri Lanka for a while, so I would like to say thank you to Alexis and Nivendra for all the good work they're doing in a country that's very close to my heart. I've spent a lot of time in and done a lot of things in, and I think this is great and really, really important work. And thank you to Manali for organizing this meeting. I hope people have found it useful.
I hope so too. Thank you very much, all of you. And I will just go into the last part of my program, and then we will wind up the program today. Okay, so we hope you found this program informative and thought-provoking, and we hope that greater understanding and empathy for those who complete suicide or who are contemplating suicide or self-harm. Please do continue this conversation and raise awareness and consciousness with your friends and your family. Make a safe space, as Fergus said, so that more people can, talk about what might be troubling them and not really engage in very extreme activities. Thank you to all those who registered, and thank you for your time and for joining us in this session this evening. Thank you, Alexis, Fergus, and Nivendra. It is such a privilege to have worked with you, and thank you for taking the time and sharing your experience and expertise and helping me put this program together and making it meaningful. Thank you to my colleagues, Tissa, Dilani, Shiroma, Manisha, and Misha for their support. And thank you especially for Shamil for his patience and his calm and confident handling of the tech. Thank you again, everyone, and good night.